Fellow Kenyans, the COVID-19 pandemic has now entered the 4th month since the first case was reported in the country. During this period of time, we have seen a steady increase in the number of positive cases. As of today, the country has registered close to 7,000 cases. In the past week alone, we have recorded, on average, 222 cases per day. This is a situation that must be of concern to all of us and demands that we reflect our attitude towards the containment measures. We are aware that these measures have led to adverse socio-economic consequences and have strained our country and have generated intense pressure to have the measures relaxed. However, the control measures to curb the spread of the virus cannot be done away with altogether. As we are seeing, countries, states, and cities that have taken extensive measures to do away with the containment measures have had to go back and impose these measures again because of the spikes that they saw. This discussion, of course, is being seriously considered, and I know that all of us as a nation are waiting to see what will be pronounced when that deadline appears. So let's wait for that and see which way we shall move. We are aware, as confirmed, the majority of people who have succumbed to COVID-19 have underlying disease conditions such as diabetes and hypertension, among others. These are non-communicable diseases whose burden to the health system is on the rise. Hypertension is one of the most common cardiovascular conditions globally, and this applies to Kenya as well. It is estimated that 1.13 billion people live with this condition worldwide, representing 31% of the adult population. In Kenya, about 6.1 million adults live with hypertension, representing about 24% of our adult population. Our Kenya Health Information Systems, during the period January to March 2020, the data from this system and reports coming from 21 counties indicate that we have 67,465 hypertensive patients that were seen and reported during this period. Of these, 18,231 cases are males, while 49,144 are females. This is only those who actually come to seek treatment and are captured in this information system. And we believe that this is just a tip of the iceberg in terms of the extent of this disease within the population. Many more are yet to be diagnosed, or many more are walking around with the disease and don't know that they actually have the disease. In this regard, the Ministry of Health has prioritized halting and reversing the non-communicable disease burden in the Big Four agenda under the Universal Health Coverage pillar. COVID-19 pandemic has exposed the vulnerability of people living with non-communicable diseases, and hence the ministry, in collaboration with the county governments, has put up measures to ensure that non-communicable disease clinics remain operational during this period. Additionally, the ministry calls upon people living with diabetes and hypertension to live healthy by consuming healthy diets based on locally available foods. A balanced diet is critical for preventing and managing non-communicable diseases and their related complications during this COVID-19 pandemic and beyond. Those who adhere to a healthy diet are able to maintain the acceptable blood sugar levels, manage their blood pressure levels, and maintain ideal body weights. A healthy diet has a variety of foods that provides the right amounts of nutrients, calories, and need not be expensive. The guidelines for healthy diet is as follows. Eat the right portion of whole grains and cereals like maize, rice, millets, sorghum, wheat, root tubers like arrowroots, cassava, sweet potato, and green bananas. Consume plenty of vegetables from all the subgroups. Green leafy vegetables, for example, spinach, sukuma wiki, traditional vegetables like managu, terere, kunde, mrenda, saga, pumpkin leaves, and starchy vegetables such as butternut, pumpkin, and other vegetables like cabbage, sweet peppers, green peas, French beans. Eat a variety of fruits that are in season and readily available in the market, such as oranges, mangoes, ripe bananas, apples, watermelon, and others. Eat plenty of protein foods such as beans, green grams, lentils, jahi, pigeon peas, groundnuts, and seeds, alternating with animal protein foods such as fish, lean meats, poultry, and eggs. Take fat-free or low-fat dairy and dairy products such as skimmed milk, low-fat yogurt, and fortified soya beverages. Restrict the amount of sugar, salt, alcohol, trans fats such as hardened fats and margarines, and saturated fats from animal sources, and fatty meats which you may consume. Avoid sugar-sweetened beverages such as sodas, energy drinks, sweetened teas, and flavored drinks. It is also important to note that diabetes and hypertension clinics are operational, and I therefore encourage persons living with non-communicable diseases to visit these clinics for their regular checkup, refilling of their prescriptions for medications, and obtaining nutritional counseling. Let's now turn to our COVID-19 situation for the day. Today, we report 268 people who have tested positive over the last 24 hours after testing 2,704 samples. This number brings our caseload of those confirmed positive to 6,941 out of 1,766 and 1,766,059 cumulative samples so far tested. Out of this number, 259 are Kenyans and 9 are foreigners. 160 are male, 108 are females. The youngest is 1 year old, the oldest is 80. In terms of distribution of the cases, we have Nairobi with the largest number of 175 cases, and these are distributed in the following sub-counties. Dagoretti North 34, Kibra 29, Ruaraka 24, Langata 21, Embakasi East 12, Westlands 11, Makadara 10, Starehe 7, Kasarani 6, Embakasi South 5, Embakasi West 5, Embakasi Central 3, Embakasi North 2, Kamkunji 2, Madare 2, and Roysambu 2. Followed by Mombasa County with 28 cases. Kisauni had 12, Mvita 6, Jomvu 4, Nyali 3, Changamwe 2, Likoni 1. Third was Busia with 18 cases, Teso South 12, Teso North 5, Matayos 1. Kiambu had 11 cases, Kiambu Town 7, Ruiru 2, Juja 1, Thika 1. Kajiado had a total of 9 cases, Migori 9 cases, Uasin Gishu 8 cases, Machakos 6 cases, Narok 2 cases, Makueni 1 case, and Muranga 1 case. The breakdown of these other counties will be provided in the statement that you will receive. Okay. We are also pleased to inform you that we have discharged 20 patients over the last 24 hours from the various hospitals where they were receiving treatment. And this now brings to 2,109 the total number of recoveries that we have registered so far. Unfortunately and sadly, we have also lost 3 more patients to the disease, bringing to 152 the total number of fatalities in the country. We send our heartfelt condolences to the family and friends of the departed. Finally, as I conclude, let me remind you that the battle ahead is tough, but it's far from lost. There is still much to be done, and our country has the determination, the solidarity, and the tools to flatten the COVID-19 curve. We can only achieve this if we pay attention to the data and public health interventions at hand. As I have repeatedly said, I want to emphasize these key messages: hand washing, maintaining social and physical distancing, proper wearing of face masks in public places, avoiding social and political gatherings. Please, let's not tire of doing this. I want to thank our healthcare workers and other stakeholders who have diligently contributed in this struggle. I thank you.
Hi, my name is Graham Kajilo from The Standard. The question I would like to ask is about the modeling that you used to come up with the numbers. I understand President Kenyatta used the worst case scenario of 45,000 people dying and 450,000 infections if 60% of the restrictions were lifted. So I would like to know what is the best case scenario in that case. And also how do you come up with the models? Which data do you use to come up with the models?
My name is Monge Maina from TV47. I have 2 questions. One, there is information that a group of students from Sudan made their way to Mombasa over the weekend, and a number of them have tested positive. Would you confirm the veracity of that information? And then number 2, how accurate is the data that you, or rather the accuracy of the results, because you have seen some people disputing that some of the patients have not died out of COVID. Thank you.
My name is Chemutai Goin from Citizen TV. I have 2 questions. Could you kindly, if you may, give us a breakdown of the deaths, especially for those with underlying conditions, what conditions and the numbers of the people that have passed away? And two, could you confirm if it is mandatory for a COVID test to be performed on a corpse, especially if it's a case of a dead on arrival, whether it's mandatory for that to be done, and just leading up to the burial protocols, especially for non-COVID related deaths?
Nancy Okware from KBC. According to a survey by TIFA, whose findings were released today, especially on matter stigmatization, 23% of Kenyans or the respondents say that they would not visit recovered patients, whereas another 41% say that they would not allow their own children to play with recovered patients' children. So when you've been doing follow-ups on the recovered patients in the country, are they still undergoing the stigma, or what can you say about this? Is there some improvement about the thermal guns that are being used to test, to check temperature at the various facilities? Can you authoritatively say that in Kenya we only have the accurate ones? Because some are saying that you go into a certain mall, your temperature reads 36, the next one 38, and thank you.
Okay, thank you very much. There are a couple of questions here which I will divert to the AG because he's in a position to respond to those. The modeling one I will leave to him. But all I can say is that modeling information is important because as we move along and generate our real-time data on this COVID pandemic, our models will serve us better because they will use this data to make those projections. So I'm expecting that as we move forward and generate more data, we will have more reliability on the strength of the predictions of our models. And which is why in the last address that His Excellency the President gave, he talked at length about the various scenarios that we would face if we lifted some of these restrictions at various levels. I think the DG will be able to talk to that a little more. Mwangi from TV 47, your query about the students from Sudan who headed to Mombasa and turned positive, I do not have that detail, but my team might have it. What I do know is that indeed, yes, there was returning Kenyans who returned from Sudan. I'm aware that they could not have come in unless they had already a COVID-19 free certificate, and I do know that most of those students were already carrying COVID-19 certificates from the institution. Actually, it was from the Uganda virus laboratories in Uganda at that time. Now, anybody can contract COVID-19 depending on who they interact with and at what time. You know, even those of us who are standing here, we may be negative today, but tomorrow if we go and, mix up with somebody who may be asymptomatic, and then we test ourselves a few days later, we might actually find that we have contracted it. So there could be a number of reasons. I don't know, but I think the DG may have some information on that case. If he does, he will respond to that. Then you also asked about the veracity of our data regarding deaths. Is it? Okay. Of the testing results. The testing results, as I said, if these individuals were coming from a country that is our neighboring country, such as Uganda in this case, these are students from Sudan, did you say, not Uganda? They were from Sudan. Okay. I knew about the students from Uganda. I don't know about students who came directly from Sudan. That information I do not have. Perhaps the DG might or might not have it. Chemtai of Citizen, the data, you want to get data on the statistics of deaths, especially deaths due to underlying conditions, cumulatively over time, what we have seen. so far of the 152 or so deaths that we have. The data is available. I think the DG might be able to address that. Do you have that data at hand, DG? Or it's data we can provide.
Yeah, we can provide.
It's data we can provide you because we do have those statistics. And whether COVID tests on corpses, posthumous testing is mandatory. From a safety point of view, and especially under circumstances where people die at home, for example, and not in a facility, where the cause of death may not be very clear, it's absolutely essential that we do that kind of test. Why? Because you know COVID-19, the symptoms and the progression of the disease and the way people move very quickly to death is very difficult to distinguish from some other diseases. Okay? That's why it is necessary to rule out before we have people handling that corpse and spreading transmission in case it turns out to be positive. As a matter of precaution, it's necessary that we do a COVID test to ensure that it is COVID-free, and then it can go through the normal burial processes, because you know in our different religions, there are some religions where the body may be handled, may need to be washed or embalmed or other things. There is no danger in spreading. But if it is COVID positive, then it goes up through the protocols that we have put down, safety protocols on how to be able to intern that kind of body. Nancy Okwaro, you informed us about this survey that was carried out and highlights the extent of stigma. I think it's a little bit shocking to see that we have almost a quarter of the population who still feel, this issue of stigma. They are concerned about interacting with people who have had the disease and recovered, or children of people who have had the disease and recovered. I think that is it's a sad state, and we must, in the strongest terms possible, discourage people from taking on that type of outlook or attitude, because COVID-19, once somebody has been released and recovered from COVID-19, it means that person has been tested and shown not to be able to carry the virus, not carrying the virus. So there is absolutely no risk or danger in that person transmitting that virus to somebody else once they have recovered. That does not mean that people may not get infected. In fact, the issue of reinfection is still very unclear as far as COVID-19 is concerned. Entirely in the globe, we are not sure whether a person who has recovered from COVID-19 is immune to reinfection from COVID-19 at a later stage. That is work that is in progress. There is research going on to look at the levels of antibody and immune response. There's a body mounts once somebody has contracted the disease and recovered, and how long that immunity lasts. That is information we are waiting for. But person who has been declared recovered from COVID-19 poses no further risk than any one of us here who is normal in that sense. And there is no need to stigmatize the disease or those who have suffered from the disease. We know the battles that we had to fight in order to destigmatize HIV/AIDS. The successes that we have made today in the fight against HIV/AIDS is to quite a significant extent due to the fact that the disease was stigmatized, people understood what the disease is, and people were able to care for those who are afflicted by the disease. Equally for COVID-19, I think we need to destigmatize this disease. Any stigma only hinders our efforts at trying to battle the pandemic. Then finally, we had a question on temperature monitors and the accuracy of these temperature monitors. There are various the monitors that are currently used widely are what we call the infrared thermal guns, which are pointed at your forehead and register temperature. And there are very many brands of that are available. Generally, if well calibrated, those instruments should be able to register the right temperature. It's not only calibration, but also how it is used and which part of the body it is pointed at. And as a ministry, I think we have tried to set some standards for these instruments to ensure that they are, one, the right instruments, two, that those who are using them have knowledge on how best to use them. That is not to say that there will not be instances where readings may vary. That's likely it could be because of differences in the way people are using the gadget, or it could even be a defect with the gadget itself. But remember, temperature is one of those symptoms that we look for. Beyond that temperature, there are other things that we look for also, clinical signs, if one is actually suffering from COVID-19. So we are aware that there is a need to be able to closely monitor and ensure that those gadgets that are being used are performing the right task and giving us the right temperatures that we need to see. So let me now hand over to the DG to respond to some of those questions that came to him. DG.
Thanks, Waziri. Let me start by Graham, who asked a question about modeling again. Definition: modeling is the science of predicting or projecting disease trends or patterns based on a given set of data. And remember, initially when we were doing these projections, we were basing our data on events outside the country, maybe from China, Europe. Now that we have done more than 3 months with the disease, we are using more and more of our data to assist us in our modeling. And you have seen with the time that what we tell you here vis-a-vis what we project, there's no much variation. And the data that we are currently using, amongst other things, include the characteristics of the patients who get the disease, e.g. whether they are symptomatic, asymptomatic, how many persons can you be able to pass the disease to in case you are infected, also known as the R-naught, and how basically you apply the containment measures that we have put in place, including how you use your masks, how you do the hand washing, and maintaining physical and social distancing. So we can confidently state that going forward, we are having more locally generated information, which we are using to be able to model, and which reflects the reality of the Kenyan situation, instead of what used to happen when we used to base our modeling on data from China and other places. And going forward, that simply tells you that things are falling into place as projected. You remember some time back we told you that going forward, late June, July, it will not be unusual to see more than 200 cases reported on a daily basis, and I think that is what is obtaining as of today. For the students who came from Sudan, yes, of course there is what we call patient confidentiality. These are cases that we have reported from Mombasa, but we didn't disclose that these people actually came from Sudan, but they are captured in our line list. Testing for COVID, yes, as Waziri said, is a good practice based on the clinical judgment of the clinician and also circumstances regarding the death of the diseased person. It is better to err and test even posthumously and protect the immediate family members and the rest of the society or community rather than leave it to chance, and then people fail to take appropriate infection prevention control measures that then will be able to expose a larger proportion of the population. The conditions, yes, predominantly those who die, majority of our patients have more than 2 conditions. And usually we have more than 2 existing conditions, majority being with diabetes and hypertension. That is the highest risk factor for COVID mortality, followed by diabetes alone, then hypertension, then other conditions including cancer. So that is why Waziri was emphasizing the need for those with coexisting conditions to continue visiting the health facilities for filling of their prescriptions, for assessment, so that we ensure that their control is good. We had a presentation today and something came out very interestingly, that for those who are HIV positive, the risk of COVID death is minimal. And we presume this is because most of our people who are on ART, antiretroviral therapy, are adhering to the treatment and therefore achieving viral suppression, and therefore their immune system is as good as those who are not HIV infected. And we want to applaud them for that, and also appeal to those who have other existing conditions like diabetes and hypertension, that adherence alone to the prescribed medicines will make your exposure much reduced, and therefore risk of death, even if you were to get COVID-19, significantly reduced. Well, the issue of stigma, yes, is a big problem, more so especially with the containment measures that are in place, because stigma will lead to further isolation, and with isolation, and that will lead to either anxiety or depression. Yesterday we engaged Kenyans under the Ask the DG platform, and our main focus was mental health. And what we need to do as Kenyans is to, 1, demystify the myths and misconceptions regarding COVID-19 so that we convey the correct information. Number 2, we must develop coping mechanisms, that even if I'm diagnosed as COVID-19, I must have my coping mechanism either from my close family members or close friends. Then you need to verify where you get your information. Either you get information from a verified source like Ministry of Health, WHO, CDC. Also, don't listen too much to the information that makes you unhappy. So if you think CNN is airing too much of COVID deaths, please switch off, flick off to another channel. So those are some of the measures that you need to put in place to ensure that you can be able to overcome this stigma. But we are working together with the counties to ensure that we scale down mental health services to the lowest level possible through the community health volunteers, so that they become the first aiders for mental health, so that they can be able to support those who test COVID positive. This does not require any unique training, including all of us who are here. We can quickly be sensitized on mental health, first aid, so that we can be able to support the rest of our families and friends. I think the issue of the thermograms was adequately addressed by Waziri, but that notwithstanding, Kenya Bureau of Standards, which is the body authorized to ensure that the standards are met, is of course on the lookout for anything in the market that does not meet the required standards, and they'll be able to take appropriate action. Remember also, because we are dealing with a pandemic, there are very many people who will come with all sorts of goods and services to be able to peddle around. So it is important that we have an oversight in terms of the machines and equipment that we use, that they are properly calibrated and they reflect the correct position, because any misjudgment using those tools could lead to a disaster. Thank you.
Thank you. Thank you.